Good evening. Today's meeting was called due to the Never event that occurred in the intensive care unit on February 1st, 2015. For those unfamiliar with this sort of event, it was first introduced in reference to patient care errors that should at no time have occurred. The list has been lengthened to indicate adverse events that are instantly recognized, severe, and typically avoidable. Present in today's meeting is myself, Chastity, a representative from Nurse Administration, Anne Marie, who is the daughter of the patient, Mrs. B, Tracy, Risk Manager, and Suzanne, the Unit Manager, and Dana, the Nurse Informatics Specialist. We will first begin by discussing patients' records according to documentation during patients' visit. Mrs. B is a 71-year-old female brought to the emergency room via fire rescue after being found unresponsive by a family member. A daughter and husband were with the patient upon admission to the emergency room. The patient was unable to speak or move her upper or lower extremities, but was alert and was able to respond to simple commands. Her fasting blood glucose was less than 20, hemoglobin A1C was 9.4, blood pressure 100/42, pulse 50, resp 25, and a temp of 90.1 rectally. She was immediately treated with hypothermic blanket, oxygen at 4 liters nasal cannula, and an amp of dextrose 50. Labs reveal lactic acid was critically high and hemoglobin was 7.4. Patient was taken for a MRI and a chest x-ray. The patient was then admitted to the intensive care unit. The attending submitted orders through the fax prescribing system from home for glucose testing 4 times a day and insulin orders with parameters, and these were placed in the paper chart. The attending also ordered for neurology, endocrinology, and a hematology oncology consult. The endocrinologist diagnosed the patient with type 2 diabetes and cirrhosis and ordered insulin administration for glucose parameters in addition to the attending, but he entered them directly into the EHR. The nurses did glucose testing 4 times a day and responded with insulin administration according to the parameters of both orders. On day 3, the nurses responded to a critically low oxygen alarm and rapidly decreasing heart rate. A code blue was initiated. The patient had a blood glucose of 13, went into cardiac arrest, died. Is there any more information you would like to add, Mrs. Anne Marie, in regards to your mom prior to us continuing this meeting?
I am so distraught. I don't know how something like this could happen. She was just with me this morning and everything was okay. Hospitals are supposed to heal people, not kill people. I don't understand why or how did you guys let this happen? The hardest part is that I'm a nurse and I know what it takes to care for patients like my mother. My mother is an intense patient, and she requires an enormous amount of effort and work to take care of all her chronic health illnesses and maintain her safety. I just fail to recognize how this could happen to my mother, and she's no longer with us.
Ms. Anne Marie, I do understand your concerns. I am too hopeful that we will learn from today's meeting and find out which processes failed. We will start with you, Mrs. Suzanne.
Anne Marie, I am sorry for your loss. I am the ICU unit manager, and our unit is a 12-bed unit. We have an average ratio of 2 nurses to every 1 patient. I'm sorry, excuse me. How did I do the average ratio of 2 nurses, 1 patient? Our nurses work 12-hour shifts and conclude each shift with verbal communication on the patient's situation, the background, assessment, and recommendation to the oncoming nurse. In the shift report, there was no mention of the double insulin orders, so it is not known if the previous nurses had noticed it. The nurse taking care of the patient stated she did have to give insulin twice on her shift. She does remember overriding an alert during one administration for the insulin, but does not recall what it was. On the day of the patient's death, we were short one nurse that shift. And the nurse taking care of your mom was also taking care of a patient that was post-op day 2 of a coronary bypass. I also did want to mention that it is one nurse for every 2 patients. I said the ratio wrong, excuse me. So that's what I wanted to add for the ICU.
Hi, I'm Anne Marie. I too am so sorry for your loss. I'm with the informatics team. I would like to just go over the DRHA informatics that were related to this case. DRHA implemented a secure and encrypted electronic health record 3 years ago throughout the facility. Computerized physician order entry, or what we call CPOE, is currently part of that EHR system. In using CPOE for medications, orders are incorporated with patient information such as other prescriptions and lab results, which can be automatically checked for potential errors or problems. This real-time cross-check is supposed to improve optimal drug selection and reduce errors at the time of ordering. It is a safer and more effective way to order for patients than the old way of using paper prescription pads and forms. There is currently an IT department at DRHA which maintains the hardware and software throughout the facility. The DRHA executives have also recently approved adding another nurse informatics specialist position to the staff. This individual will be used to ensure the knowledge, information, and data needs for projects and programs used in the facility are met, as well as make certain that staff and stakeholders' needs are met when they need assistance and help with the IT technology. There are 2 IT staff in our IT department during the day. One IT staff member is on the night shift, and then there's another IT staff member that is on call. As far as the EHR and new staff, it is mandatory to do orientation for the EHR system. They take usually a day and a half during their week-long orientation period. The orientation to the EHR system for new staff continues throughout the 90-day probationary and preceptorship period. There are IT and EHR policies and procedures in place at DRHA. These policies and procedures were written at the onset of the EHR implementation, and they remain in circulation. Also, DRHA places a high priority on meeting all meaningful use criteria with their EHR system. The facility is now in the midst of a month-long process of obtaining staff feedback regarding current EHR benefits and barriers noted during their daily clinical use. We hope to use this data collected to be for quality improvements needed in the systems and processes. On the day of the event being reviewed, there were a number of calls to IT from several departments indicating that some slow computer function and spotty service were noticed for approximately 1 hour that day. This did slow down workflow for a short time. IT did investigate the problem. They reported no server downtime, and the emergency generator use was not required, so they did not find anything specific in that area. Specifically in the ICU where your mom was being treated, they do use the EHR system. There is functionality of clinical alerts. There is a functionality for communication with cross-disciplinary team members throughout the facility. There is also automated interface with the glucose readings, which populate immediately into the medical record when taken by the glucose or glucometers used in the ICU. The other patient vital signs do have to still be manually entered by the ICU staff. There are plans to implement a vital sign interface, but no start date is available as of today. And that's the information from the informatics on that date. Thank you.
Ms. Anne Marie, I too would like to extend my condolences on the loss of your mother. It is my responsibility to ensure you are apprised of every step taken to not only find out what happened to your beloved mother, but to make the environment safe for the next patient. The goal of a risk management team is to find out and identify the systemic problems in the specific clinical areas, such as the intensive care unit where your mother stayed, as well as to engage clinicians and educate them about the need to modify the specific behaviors, as well as working collaboratively with the other team members, such as Suzanne, Dana, Chastity, and myself, to educate and to help design environments that would be more conducive to the delivery of safe care. So that is my role as the risk manager. And again, please accept my sincere apologies on the loss of your mother. And we hope that you will entrust us to find out what happened and to get the answers that you would need to hopefully provide you with some comfort in the loss of your mother.
Ms. Anne-Marie, we would like to again thank you for being part of our meeting today. We offer up our condolences in your time of grief. Is there anything you would like to ask us before we conclude today's meeting?
I want to thank you all for sharing your input and for your sympathies. Of course, it's way too early for me to decide how I'm going to proceed.
Yes.
But one thing I know for sure is that I will expect a very detailed explanation on how this happened and how the hospital intends to make sure that this never happens again to another patient.
Absolutely.
We do understand, Ms. Anne-Marie. Is there any other questions that the teammates might like to ask?
Yes. After listening to the care provided to the patient, Mrs. B, I wonder why two physicians placed orders under two different ordering systems. If so, how are physicians able to provide continuum of care without first viewing what other physicians have previously ordered? Why are there more than one options of prescribing systems for physicians? Are there safeguards to alert nurses of duplicate orders?
Thank you for that, Ms. Tracy. And thank you for everyone who attended. Our goals for this meeting is to make sure we never have another never event. By asking ourselves these hard questions, we can commit to reevaluating our policy and procedures in the hope of continuing safe practices for our patients.
Thank you.
I think that's the conclusion of our meeting. Ms. Anne-Marie, we will submit a report to you in a timely fashion, and please contact us if you have any further questions. Thank you.
Thank you.
Thank you. We're sorry.